Hello, my name is Angela Smith, and I am a DNP student at Maryville University. Today, I will be presenting to you my scholarly project with the title of Primary Care and Mental Health Integration. Nearly 20% of Americans have a mental health disorder, and unfortunately, more than half of these patients never receive treatment. Mental health diseases affect overall individual wellness, meaning that an individual's emotional status does affect their motivation to improve their chronic disease management skills. The 2020 Healthy People Mental Health and Mental Disorder Objective encourages the expansion of increasing the percentage of primary care clinics that do provide mental health services. The mental health integration into the primary care settings increases the availability of the services and provides access to additional resources. Several published peer studies have drawn attention to the actuality that having reliable collaborative care and interdisciplinary communication is beneficial. The purpose of my project was to expand the medical professionals' knowledge regarding the benefits of the integrated care. The project focused on the advantages of collaborative care for both providers and the patients. The primary care and mental health project included veteran subjects, both male and female, that were greater than 18 years of age and who had received primary care services at the Department of Veterans Affairs for greater than 5 years. This sample was diabetic patients that were diagnosed also with depression. One of the symptoms were diabetics that had depression who were receiving mental health services, and this meaning psychotherapy or psychiatry. The second sample of veterans were diabetics with depression who did not receive this mental health treatment. There was a statistical comparison of the patients who did receive mental health services versus those who did not by comparing hemoglobin A1C levels. A one-tel independent t-test was performed and finalized with an examination of these comparisons. So the inquiry was, in diabetic patients with depression, do patients who receive these mental health services have improved chronic disease self-management, or meaning they improved their A1C levels? To provide some background on my platform, patients in both diabetes and depression tend to struggle with their chronic disease management. Often, a patient's lack of mental health disability influences their desire to complete necessary self-care behaviors. Clinical research has supported a combined medical and mental health treatment should become a standard practice in managing these patients because there are notable medical improvements. With mental health wellness, patients are motivated to improve their overall wellness and maintain a better quality of life. Research substantiates that collaborative care, both primary care and mental health intervention, improves health services on multiple levels. Integrated care meets twofold patient needs and decreases care cost through health promotion. Knowing these insights will provide awareness of the project's pertinence and focus on the impact primary care and mental health integration will have on this population's well-being. The significance to the nursing profession is supported by, in 2019, a study was conducted on a sample of nurses and nursing students. The group was interviewed and the researchers identified that most nurses found the integrated care rewarding. Many verbalized they developed the necessary skills to become a productive member of a cohesive healthcare team. The comprehensive medicine and mental health education that advanced practice nurses, or APNs, received prepared them to become an innate part of a care management and a holistic wellness approach. The primary care settings have facilitated their role expansion and closely paid attention to direct evidence-based practice turning into protocol. In relation to healthcare organizations, it is felt that they can expand access to care and improve collaborative care and communication between different specialties. By integrating mental health screening into the primary care setting, care costs are influenced using a proactive care approach and the implementation of preventive services. There is also a care cost effectiveness when close attention is directed toward interdisciplinary elements and collective interventions. I received a lot of support for this project. The project's phenomenon of interest was first presented to the Maryville University IRB Board for approval. Support was received from the project's faculty chair. The healthcare organization within the research that was conducted, the director evaluated the proposal and provided direction for gaining access to the statistical databases for the gathering of my testing samples. A staffed psychiatric mental health clinical nurse specialist in one of the community outpatient-based clinics was the professional resource and assisted with reviewing the data and developing conclusions. There was also the involvement of a community member who was a licensed social worker that provided direction and helped me facilitate the process for efficacy. This member also assisted with reviewing and making provisions to the final project presentation. Supporting literature. A literature review was conducted on the English language peer-reviewed articles published in the years between 2012 to 2020. The search of these peer review article databases using the keywords and encompasses originally produced 988 articles. The key concepts then narrowed the results down to 2004 using the Boolean operators. The final critiquing resulted in 27 articles, with one being a hallmark that was written in 2012. The viewpoint stood out that in the diabetic population, where there was a dual diagnosis of depression, it was common. With mental health wellness, patients became more invested in their care. Outcomes provided evidence noting that improved medical and mental health regimen adherence occurred. So the key concepts used. Collaboration means collaborative care that recognizes twofold patient needs and provides an integrated approach to health promotion. Integration means facilitating the identification of the relationship between the dual issues. The collaborative environment or integrated environment enriched multiple care facets. The third is benefits. Definitely a research outcome substantiated that the primary care mental health integration patient care model benefits healthcare systems on multiple levels. Patient engagement and improved quality of life also found to lower cost. We do have to note that there was some gaps in evidence. The most prominent gap in the literature review was the scarcity of studies that applied an actual integrated care intervention and then followed up with accessing or looking at and assessing the outcomes. These studies did encourage future research to concentrate on the integrated interventions. The research should additionally analyze multidisciplinary relationships and partnerships and overcoming implementation barriers. So what conceptual framework was used for this project? The theological framework that was used for the project was the translating evidence into practice, or the 4E approach. This corresponded appropriately with the proposed project. The 4E's collaborative model helps facilitate the implementation of large-scale knowledge and then focuses on the change at a systematic level. The 4 steps of this approach includes engaging the change participants, educating on current scientific evidence, then executing the standardized change, and finally evaluating the measures against the baseline to assess its success. This will be adequately applied later in this presentation. The project methodology was an actual quantitative research analysis, as this method is commonly used to test hypotheses and affords the measuring of variables. The retrospective chart review afforded the study to evaluate cause and effect. A nominal scale was utilized to identify if the mental health intervention variable existed. 1 presented yes and 2 presented no. The interval variable represented the A1C laboratory test results and variability. Convenience sampling was used because it is a non-probability method that was used and effective for the project. Data was extracted retrospectively from electronic medical records with veterans diagnosed with diabetes and depression. The primary 51 electronic medical records consisted of veterans age 18 to 89 who had received 1 calendar year of mental health integration, reminding you that this meant psychotherapy and psychiatry. The secondary 51 electronic medical records consisted of veterans also 18 to 19 years who had not received any mental health intervention. 112 charts were collected. All veterans with diabetes and depression who had had greater than 1 year of primary care services between May 2, 2020 and August 22, 2021 were reviewed for possible inclusion in the retrospective chart review. The hemoglobin A1C levels were collected retrospectively from the electronic medical records during this period. A, those completing greater than 1 year of mental health intervention, and B, those who had not received mental health intervention. If the veteran did not have a hemoglobin A1C level completed during this time, they were eliminated. Additionally, if the veteran had a charted neurocognitive disorder, the chart was excluded from the project, meaning any mental health neurocognitive disorder could have been memory or cognitive difficulties, dementia, schizophrenia, psychosis, or even a delusional disorder. Note there was no recruitment of veterans for this project. This is the data collection tool that was used for the project. It was an individual data sheet. There were 2 different spreadsheets, each representing the different intervention variable. No actual copyrighted standardized collection tool was used. The data collection sheet was personally developed for the project's intent and as recognized by Pilot and Peck 2021 to guide the collection process through an appropriate procedure. The project could not have been completed without encompassing the use of several resources. Dr. Gail Pitroff was the assigned faculty chair who provided me with direction and aided with meeting the doctoral program requirements. Dr. Mark Pauls assisted with the statistical analysis needs. The VA Community Outpatient-Based Clinic was the portal for the data collection. The clinic's medical record team and IT staff agreed to contribute as necessary. The project also had an active community member, Ms. LaDonna Gleisinger, who was a licensed social worker, and she specializes in mental health psychology. She provided professional guidance. Finally, the Maryville University IRB committee evaluated and approved the project's acceptance. Here is an actual table of the resources needed and the budget. To kind of tie into the presented budget from the prior slide, the project time frame was approximately 12 weeks in duration. There was no in-person participants. However, there was a primary investigator overseeing the project and then a co-investigator who performed the actual electronic medical record retrospective review. The budget financial costs were in that prior table. The total cost for the project was $6,745.55. There was no foreseeable physical, psychological, social, economic, or legal risk that resulted from this retrospective study. One potential risk, of course, was the breach of confidentiality. However, this risk was minimal. All data presented had possible patient identifiers removed. The potential risk did not outweigh the benefits of incorporating the mental health services into the primary care setting. To comply with HIPAA regulations, the data collection sheet was stored on a password-protected computer, and the computer was locked in the researcher's home office desk cabinet with assessment only to the project's author during the collection period. For data analysis, a one-tailed independent t-test was performed and verified and finalized with an examination of comparisons. A measuring device or design was often used to compare the distribution of numerical variables in two different study populations. Each sample was comprised of 51 charts of priority with a null of 102 electronic medical records. There was a 0.5 effect size or difference, an alpha of 0.05 significance, and a power of 0.8, which is probability. Analyzing and comparing the similarities and contrast between the two groups' A1C levels provided a good depiction of the differences. The International Business Machine Corporation, or IBM, statistical package for the social sciences, SPSS, was utilized for the comprehensive statistical data analysis as a program is an effective tool to compromise of data sheets and multifunctional devices that facilitated the advanced statistical analysis. So now we begin with the results. The method of evaluation for this project was an experimental design using quantitative data. The convenience sampling, also known as available sampling or non-probability sampling, was utilized for the project. The two sample comparison assessed the variances in the patient's diabetes self-management skills between those who had received mental health intervention and those who had not. The study samples, which were extracted from the chronic disease databases and represented the population at hand, was obtained in a retrospective manner from electronic medical records. The project's descriptive data collection tool provided ease for substantiating and collecting a consistent analysis of a constant variable. The tool's measuring design offered a distribution comparison of the numeric variables in the two different study populations. The use of the numerical scale identified those patients who had received mental health interventions and evaluated the level variable of its existence. Analyzing and comparing the similarities or contrast between the two groups' A1C levels provided an accurate depiction of the differences. The datable portrayal statistically identified a phenomenon and assessed concept prevalence. Ravy of 2016 states that this informative progression constructs meaning to obtain experiences. There were detailed literature factored from the implemented process that created the reality of the assessed experience, providing both high availability and reliability. By incorporating best practice as recommended by the 2020 Healthy People Objective, there was assurance of data quality and accuracy. The recommended practice guideline innovation was substantially deemed fitting after the consideration of the researcher's project through the faculty chair. The university statistician conferred with the research and the faculty. After that, the conclusion of the raw data collection, the statistician believed that the analysis method selected was applicable. Ethical considerations. As mentioned prior, one potential risk was a breach of confidentiality. However, this risk was minimal. All data presented had positive patient identifiers removed. The proposed practice change would provide veterans with diabetes and depression improved accessibility to mental health care. At the end of the data collection process, the researcher destroyed any patient-sensitive identifiers. The extracted data constituted the minimal necessary data to accomplish the project goals. Electronic medical records with the diagnosis of diabetes and depression were identified by the first letter of the veteran's last name and the last four of their Social Security number. On the data collection sheet, the records patient identifiers were given a numerical number like 1, 2, 3, 4 to correspond with the data collection sheet. This is the descriptive analysis of the individual hemoglobin A1Cs. The determining factor was to assess and compare these levels. Sample A is the group that did receive mental health services, and sample B is the group that did not. The hemoglobin A1C levels were collected retrospectively from the records from May 2nd, 2020 to August 22, 2021. The second graph shows an average of the past year's hemoglobin A1C levels. Depending on the patient's diabetes stability, the number of clinic visits and occurrences over the last year factored into the collection of anywhere from 1 to 4 A1C levels that contributed to the average. The university statistician aided in the data analysis for the staging of these results. The degree of variability was low. These two provided tables are examples of the sample comparisons. The one on the top illustrates the average where the veterans did receive mental health intervention. The A1C average was 7.02, and then the levels of veterans who did not, 8.10. The lower table shows the significance, and then it also shows the P level. The effect size indicates that it was large. This calculation is provided below. Because the P level is less than the significance, there is sufficient information to suggest a decrease in A1C levels with treatment. The achieved power of the study was 0.9644, which is considered in high strength. The outcome implies that the null was rejected. Outcomes. Before the implementation, there was no intervention to assess the integration into primary care with mental health involving diabetes and depression. There was no determination if the veteran experienced an increase in diabetes self-management skills post the mental health intervention. The project was a quality improvement, and it was felt it would potentially benefit future veterans seen in the primary care clinics as a result of providing knowledge that if they use this to promote this type of change in healthcare practices, there would be increased and improved outcomes. There were barriers, however, because the time duration of the participants' diabetes was not taken into consideration, nor was there notation of any comorbid chronic diseases. It is known that often the length of time that one has diabetes, the more complex the disease can be to control, and frequently management is complicated by further development of these chronic diseases. These two additional factors could have impacted the ultimate A1C outcomes and studies concessions. In short, this project's variance was mainly used to calculate the deviation between the two defined sample groups. Strength of the projects do include that there was greater than 1% improvement in the patients who did receive intervention, and the results were consistent with prior studies. Future researchers are encouraged to decrease the variability by shortening the sample's age group and initiating a sample exclusion of diabetics who are greater than 10 years diagnosed. The random sampling did help with this and provide equal opportunity to each group. In limitations, it's challenging to avert bias, but the random sampling, with only having one research to collect data and then regulating the data storage and management, contributed to this. Future primary care mental health integrated subjects, it is encouraged that they recommend and look into the integrated care studies with the implementation and also by reducing age, length of illness, and comorbid noting of chronic disease. The aim of the project was met, and the outcomes of awareness of the benefit of mental health and integration in primary care. So let's quickly do a qualitative data summary. Let's assess contrast, assess arguments, and then find meaning. We are referring back to the 4E approach, engaging contributors. This was a team of primary care providers and mental health specialists that reviewed the research and then looked at the applicable evidence and assessed and applied any hurdles to make the involving organization culture, teamwork, and communication work. We wanted to make others think. Engaging the share taker, this occurred at all levels of staff. Those who imposed the innovation were then presented with the literature that has supported the need for change and seeing this common relationship. Execution, there was the intervention and implementation as designed and made around barriers and fabricated the redesign. There was educational resources provided to all staff to help them build understanding. Finally, the evaluation stage. This occurred across the team and interlinked to all the outcomes that were appropriate to appraisals. Clinicians and partners foreseen the change to make change of expected patient outcome improvement. The research data was compared to prior outcomes. The translating evidence model proved to be successful in collaborative care. These were new related relationships, should promote the interdisciplinary change and confirm our conclusions. There is justification that additional research is needed to implement and look at the integration into the clinical setting. Healthcare practices should be implemented because there is a noted lessening of costs, increased productivity, and improving of clinical outcomes. Conceivably, a qualitative study could be done in the favor to assess a patient's and provider's perspective to the integrated model. Sustainability should be done by education, providing extra research and healthcare practices that is useful for scientific inquiry. Now that we have reviewed the results, we have to remember dissemination of the outcomes are of vital importance. Critical information will be given through research product, research symposium, and diverse professional education that is given possible peer-reviewed journal publication. The information distributed will highlight the successful integrated information while in all assets distinguishing the audience of which it is shared. I respectfully appreciate your time and I hope you enjoyed this presentation. Thank you.